Okay, gosh, I'm really sorry about that. Thank you for pointing that out. All right, so for everyone on Zoom, basically, short story is I've been very interested in complex PTSD as kind of a potential alternate formulation for borderline personality disorder, and this is what we're going to talk about today. So, so the idea of complex PTSD is not new, been around since the late 80s, and Dr. Herman kind of came up with this to really describe the more complicated, particularly emotional and interpersonal difficulties associated with long-term trauma. Here. And so after she published this work, the academic community really started taking interest in this idea. And within the next several years, by the early 90s, there were multiple people who started to think about this from other diagnostic formulations and consider putting it in more formal diagnostic schemas. So the DSM-4 had a PTSD task force that actually spent a lot of time looking into this and kind of determining if they wanted to make it a formal diagnosis or not. They ended up not. However, they did create this associated feature of PTSD called disorders of extreme stress, not otherwise specified, or DESNOS. And this essentially acknowledged that folks with prolonged trauma can have alterations in kind of the following 6 areas of functioning, which were similar to Dr. Herman's postulations. So regulation of affect and impulses, attention or consciousness, self-perception, relationships with others, somatization, and systems of meaning. The ICD folks also kind of came back with their interpretation of this, which they called enduring personality changes after catastrophic experiences. And interestingly, they decided to classify this as a personality disorder. So, and they didn't make it a formal diagnostic code, but they defined their version as enduring personality change for at least 2 years following exposure to catastrophic stress. And this is like stress that's so extreme that it's not, really explainable by just, it's not necessary to like consider other personal vulnerability in order to explain the distress and the severity of it. And again, they kind of defined their syndrome as characterized by distrustful attitudes towards the world, social withdrawal and estrangement, chronic feelings of emptiness and hopelessness, and also a feeling of constantly being on edge, like threatened. And they also acknowledge that post-traumatic stress disorder may precede this type of personality change. The DSM-5, when it's time to upgrade from the 4TR, also considered this very heavily too. And they ultimately decided not to add complex PTSD due to their feeling that there was not enough empirical evidence to distinguish it from actual PTSD. So they kind of formulated it more as like a severe presentation of PTSD versus a separate diagnosis. They did make some changes to the PTSD diagnosis in DSM-5. So they moved it from anxiety disorders to trauma and stressor-related disorders. And then they also expanded some of the symptoms to include negative alterations in cognitions and mood. That's like a lot of the negativistic thinking, poor self-identity, constantly dysphoric mood, that kind of thing. That kind of gets at some of those complex PTSD symptoms. And then they also added a dissociative subtype, which I think was also their way to try to acknowledge some of these additional symptoms. And they, of course, did keep borderline personality disorder under the cluster B personality disorders in DSM-5. So the most recent iteration of this has been the ICD-11, which came out in 2022. I think it was, in the works for a couple of years, but it was kind of formally released in 2022. And they decided to go ahead and formally make this a diagnosis. So they classified it as a stress-related disorder, not a personality disorder. And they defined it as, so you do have to have an exposure to an event or a series of traumatic events. They say horrific nature. Again, don't really know exactly what they mean by that, but they do say that most commonly this is prolonged or repetitive events. with things like torture, concentration camps, slavery, genocide, organized political violence. And then they also added prolonged interpersonal violence or repeated childhood sexual or physical abuse as well. And a lot of the previous iterations did not necessarily include interpersonal violence in their definitions. So the formal criteria that the ICD-10 committee decided to include was, there's kind of like two sets. So the first set are classic symptoms of PTSD. So basic kind of re-experiencing of traumatic events, whether that's intrusive memories, nightmares, flashbacks. And then secondly, avoidance of reminders of the traumatic event. That can be both external, like not going to a place where trauma happened, or not driving a car after you've had a motor vehicle accident, or internal. So like avoiding certain memories, cognitions, emotions that remind you of traumatic event. And then the third is this essentially hypervigilance, exaggerated startle response, perception of heightened current threat. And then the second component, and this is, I think, the more interesting part, is you have to also have 3 elements within the realm of disturbances of self-organization, or DSO. So this will come up a lot later. But the first criteria here is severe and persistent problems in affect regulation. So being either very emotionally reactive, having violent outbursts, or conversely, emotional numbing. Number 2 is persistent beliefs about oneself as diminished, defeated, worthless. Just again, a lot of those negative self-cognitions. And then the third is persistent difficulties in sustaining relationships. So this really gets at the interpersonal difficulty that a lot of these folks experience. And here on the left is something I've taken from DBT, which is kind of the thermometer of emotional arousal. And I actually really like this as an illustration. A lot of you residents have seen this before, but essentially, it's kind of a depiction of where someone might be on the emotional arousal scale. So here at the top is hyperarousal. So these are folks who are just like very over animated. They might be very reactive to things, irritable, just, kind of completely over the top, dysregulated. And then here at the bottom, you have hypoarousal, which also isn't good either. So here you are kind of understimulated emotionally. You might be kind of numb, detached, and really that's not a good place to live either, because you're not fully kind of connecting with, normal range of affect. So really where you kind of want to be for optimal human functioning is in the zone of optimal arousal, somewhere in the middle, where you're still having emotions, still able to react, but not like getting so dysregulated that you can't complete your goals, things like that. And this is just, again, kind of a diagram from one of the papers that I looked at a lot. This top group is just the diagnostic realms for PTSD. So again, avoidance, re-experiencing, sense of current threat. And then B down here is complex PTSD. So again, you still have the avoidance, re-experiencing, sense of current threat, but you also have the affective, either numbing or overreactivity, persistent negative self-concept, and then difficulty with interpersonal relationships. Similar to the DSM, the ICD also requires that the symptoms cause significant impairment in functioning. And they also listed a bunch of additional clinical features that can, but don't have to be present. So these are things like suicidal ideation, self-harm, substance misuse, depressive symptoms, psychotic symptoms, somatic complaints. And interestingly, when they've kind of compared PTSD to complex PTSD, usually with classic PTSD, you kind of have a resurgence of symptoms in the setting of trauma reminders. So people can, obviously start having a lot more flashbacks or avoidance or hypervigilance, kind of in a more of an intermittent pattern. But with complex PTSD, the symptoms are really more pervasive, they're persistent, they're present in a variety of contexts, which sounds a lot like personality disorder diagnostic criteria to me. So it kind of begs the question, is complex PTSD just borderline personality disorder? The literature would say no, they are two separate things. Primarily the differences being that with complex PTSD, by definition, you have a trauma in your past. Whereas folks with borderline personality disorder do not necessarily have to have a trauma that preceded the development of their symptoms. Personally, I don't know if I've ever seen one of my patients with borderline not have trauma. So that for me is not like 100% distinction. But the bigger distinction that they kind of talk about is the way that these patients present in those DSO symptoms. So again, that how they conceptualize self, how they deal with affect, and how they interpersonally interact with people. So so people would argue that in complex PTSD, the kind of sense of self disturbances or more of like a worthless, shameful, I'm damaged kind of ilk. Whereas in borderline personality disorder, the sense of self is very fragmented and unstable. In complex PTSD, they have more emotional numbing, so they're kind of on the lower end of that thermometer. Whereas with BPD, they are more at the higher end, the overreactivity, the lability, dysregulation. And then in complex PTSD, the interpersonal relationship patterns tend to be more detached and avoidant, which is really coming from a fear of closeness, getting close to someone else. Whereas again, in borderline personality disorder, really the interpersonal relationships are volatile, they're intense. They can go from really close to really bad quickly, and it's more related to this fear of abandonment. Folks would also argue that there's more impulsivity, suicidality, and self-injurious behavior in borderline personality disorder. Although again, we saw in the ICD-11 that they recognize that can be part of complex PTSD too. So, you know, personally, I think in the real world, there's probably more similar about CPTSD and borderline personality disorder than different. I have just as an exercise kind of tried to tease this out in some of my patients, and really it's not easy. I think a lot of symptoms overlap. A lot of times patients have a hard time describing their own experience of things. So it's also hard to kind of get that clear history. And sometimes, I mean, I just kind of feel like it's more of an academic distinction versus an actual kind of practical one. I think also there's just a lot of murkiness with exactly what role trauma is playing in both of these diagnoses. So like for complex PTSD, as you saw, you have to have a preceding complex trauma, but that has to lead to classic PTSD symptoms as well as the DSO symptoms. Whereas like a lot of my patients don't really present that way. They actually don't have a lot of classic PTSD symptoms. It's more the DSO side of things that's really kind of derailing their lives. And maybe that's borderline personality disorder, but again, you know, which one fits better? I don't know. So those are kind of my feelings. Honestly, I kind of use them, I see them more interchangeably than distinct. However, the literature does distinguish them. And so what I'll kind of do for the rest of our talk is present information specifically related to complex PTSD. There are some studies that directly use the ICD-11 criteria, but again, since it's so new, there's not actually not a lot out there. But one of the kind of core features is really the kind of type of trauma that precedes this. So again, as we mentioned, it's almost always chronic and repeated trauma occurring over months to years, to decades of someone's life. Again, just a lot of really kind of persistent, oftentimes interpersonal types of trauma are at play. There's this idea of polytraumatization that, you know, again, you're just having so many kind of traumatic insults from multiple directions. There's also some evidence that there's a dose-response relationship, specifically when it comes to interpersonal trauma. So like the more domestic violence you have, the more kind of childhood abuse you have, is directly correlated with like how likely you are to meet criteria for a complex PTSD diagnosis. And not surprisingly, the timing of this trauma also plays a role. So early development, childhood, adolescence, these are particularly vulnerable times to trauma and to folks, especially who are going to be developing complex PTSD disorder down the road. And this makes sense, right? I mean, the developmental goals of childhood are forming secure attachments, communicating with your primary caretaker. As an adolescent, you're looking at the development of personal identity and social relationships. So when you're having abuse or neglect, of course this is going to change the way you kind of develop these ideas in your head. And unfortunately, we also see that early life trauma kind of begets more trauma. So there's a lot of interesting research and literature into that too, if you're ever interested. I won't talk too much about ACEs because I think a lot of us are already familiar with this idea, but I did want to mention them because I think that they are such a big role in kind of the development of complex PTSD and BPD. So if you're not familiar, the Adverse Childhood Experiences Study was done by the CDC and Kaiser Permanente in the mid to late 90s. They surveyed about 17,000 HMO members in Southern California. Notably, this was kind of essentially a private practice population. So it was a lot of pretty wealthy folks, a lot of high functioning folks. But despite that, almost 2/3 of them reported at least one adverse childhood event. And these were the original 10 that were on that first study. And 20% of them reported 3 or more. And this was important because as they looked down the road, they did find that the increasing number of ACEs that someone had was increased or was associated with increased likelihood of adverse physical and mental health outcomes. In about 2012, 2013, they actually decided to expand the original ACEs survey with the Philadelphia expanded ACEs. They looked at about 1,700 adult participants in Philadelphia, and this was a much more diverse group of folks that they looked at, both socioeconomically, racially, et cetera. And they added 5 new community level stressors, which are listed here. So witnessing violence, feeling discrimination, feeling unsafe in your neighborhood, being bullied, or having lived in foster care. And so perhaps not surprisingly, there was about 70% of the adults in this study reported at least one ACE, and 40% reported 4 or more. And actually, I went to an interesting talk by the Louisville Metro Public Health Department, I think, like last year or the year before, that was about kind of trauma-informed care and adverse childhood experiences. And they said that just by being born in the state of Kentucky, you statistically already have like 1 or 2 ACEs under your belt. I would say possibly more. So yeah, going back to the idea of attachment, how does abuse, neglect really affect the way kids start to see the world? And we do know that it disrupts the developments of internal models of seeing the world, emotional bonds with other people, especially if the abuse is coming from a caretaker. And I mean, it just makes sense. But this does kind of downstream, affect how you perceive intimacy, relationships, your sense of safety, and can really lead to a disorganized attachment style. And so in a disorganized attachment, the kid is oftentimes kind of alternating between simultaneously wanting to be close to their caretaker and seeking protection, but then also rejecting that caretaker and like having a lot of distance and withdrawing due to fear of abandonment or abuse, what have you. So really, this can kind of present chaotically sometimes. It can, there's alternating neediness, but then rejection and aggression sometimes. So it's kind of a very all over the place type of attachment. And studies have shown that these kids who develop a disorganized attachment style really have a much more higher likelihood of having severe emotional dysregulation in adulthood versus like a secure, anxious, or avoidant style. There's also neuroimaging evidence that they have larger amygdala volumes. So again, we'll talk about this a little bit later, but the amygdala is kind of the fight or flight, anxiety, emotion, reactivity type of center, and then reduced connectivity to the prefrontal cortex, which is more of the higher level cortical function that kind of downregulates some of that reactivity. And this is very similar to what's seen in PTSD, or I'm sorry, borderline personality disorder. I'm not going to go into this too much, but essentially if some of these symptoms present in a kid under 5 years old, they may meet criteria for reactive attachment disorder, which again is characterizing a lot of the same symptoms we see in BPD and complex PTSD. One of the most, I think, interesting associated symptoms with complex PTSD is dissociation. And again, it's not formally included in that ICD-11 criteria, but it is acknowledged in the associated symptoms part. And it is statistically more common in complex PTSD versus classic PTSD. We don't fully understand dissociation, why it happens, but there is some thought and theories out there that it's perhaps like a way to compensate for extreme stress or dysregulation. So if you're experiencing something so horrendous, so horrible that you like physically can't be in your body, dissociation might be a way to kind of like, deal with that essentially temporarily, where you kind of just leave, you just check out, you're not there. And they've done some really interesting studies into this. One of my favorites that I came across, which I kind of don't know how this passed IRB approval, but was an fMRI study done in Germany, published in 2017. And basically they took 17 patients with borderline personality disorder, and they induced dissociation in them. So they used these scripts that were actually based on personal experiences of the patient, where they dissociated, and then they recorded them, and then they read them back to the patient while they were in the fMRI, so that they like essentially dissociated in there, which sounds pretty horrible. But they took that group and they compared it to 12 patients with borderline personality disorder who were not dissociated, and then 18 controls. While they were in the MRI, they asked them to perform these emotional working memory tasks with either neutral or negative pictures, and then kind of like saw what happened. And essentially, the short of it is that the dissociated borderline personality disorder patients showed decreased working memory and less amygdala activation than the controls or the non-dissociated BPD patients. So essentially, the postulate was that these dissociated folks, they were not letting their amygdala get so out of control. Like it was just with the negative pictures, they were kind of just like, they were out of it. Their amygdala wasn't like firing like it normally would. And then also they weren't able to kind of use their working memory to kind of encode or maintain particularly emotional memories. Yeah, so that was very, very interesting. Again, it doesn't really tell us about the directionality of that association. Is there something about just being in a dissociative state that caused that, or is that all kind of the cause or the purpose of this dissociative state? We don't really know, but interesting. Psychotic symptoms are also a really interesting associated symptom with complex trauma. Most commonly, they are either auditory or visual hallucinations, and they can be related to the trauma, but they don't necessarily have to be. I have seen actually quite a few patients with psychotic or quasi-psychotic symptoms who I've kind of formulated as borderline personality disorder or complex PTSD. And most of them have been women. Most of them have been kind of in their 30s, 40s, 50s. And a lot of kind of manifested as paranoia, but then a lot have actually had true auditory and visual hallucinations. There was one lady who had essentially been in an interpersonal violence relationship with her husband for probably about 25 years. He had just died, but she started having these vivid visual hallucinations of him cheating on her, which was part of the interpersonal violence as well. And just very graphic. And she would see them pretty much every night. And it was very distressing to her. She knew they weren't real. She knew that he was, not there. That wasn't actually him. But it was fascinating because she had no other, symptoms of a primary psychotic disorder, no mood symptoms. It was really just, pretty related to the trauma. I've seen that with a couple other folks too. There was a pretty big cross-sectional study of patients in the UK and South Korea who were exposed to developmental trauma, where they looked at psychosis, and essentially, I won't go into all of it, but they did find that complex PTSD had a significant positive association with psychotic symptoms, whereas classic PTSD did not. And they really found, when they kind of broke it down by symptom domain, that it was those DSO symptoms that were kind of driving that association. So, how common is complex PTSD? I kind of took a lot of these numbers from a bunch of different papers, but some surveys, and these all did look at the ICD-11 diagnosis of complex PTSD. So they estimate that lifetime prevalence of adults in the United Kingdom was about 13%. Interestingly, emergency responders is about 15%, US veterans about 13%, and refugees and asylum seekers, it kind of jumped up from there. It was about 16 to 38%. Very interestingly, and I would believe this, patients in mental health treatment settings, about 36 to 50% of them actually met criteria for complex PTSD. And in my clinical work, I would say that's pretty accurate for me. I think it's probably different for a lot of us who are seeing different groups, but I would believe that. There was also another study that was conducted in a Danish outpatient psychiatric population, and they found that out of, I can't remember how many people they surveyed actually, but it was about 36% met criteria for complex PTSD, whereas only 8 met criteria for classic PTSD or borderline personality disorder. I think classically we do tend to think of women being more likely to have like borderline personality disorder symptoms, complex trauma. But really, when I was going through the literature, there wasn't a clear correlation there. The WHO did feel like that was the case, and women with complex trauma tended to have more distress and impairment than their male counterparts. But other studies really found that there wasn't so much of a difference, and men were equally as affected. There's also, a lot of studies tried to look into kind of the comorbidity between complex PTSD and borderline personality disorder. So they did find that like if you have borderline personality disorder, you're more likely to also meet criteria for complex PTSD versus the other way around. So those with complex PTSD don't necessarily often or always meet criteria for borderline personality disorder. There's also quite a few kind of trauma-specific and cultural factors that are really interesting. I won't go too much into this because there's a lot out there, but it's just interesting that when you think about the types of trauma that precipitate complex PTSD, like war, genocide, systemic political violence, oftentimes these are things that are affecting large groups of people. So it's not just like isolated to one person or one family. It's like a whole community or a whole village, for example. And so that in turn creates more trauma, kind of collective trauma. It decimates, social support networks, resources, things like that. And it just kind of goes on from there. There's also this interesting phenotype of the victim perpetrator, which has been described in the literature as people who have been forced to, I guess, be in roles such as like being a child soldier or a gang member, where you are committing pretty horrific atrocities to other people, but you also are being traumatized by doing that. And so in this population, you tend to see a lot higher rates of dissociation and emotional numbing, which makes sense. If you're forced to do something horrible that you actually don't want to do in your heart, you can imagine just needing to kind of not be there or not be present. And in some cultures, manifestations of trauma can often tend towards the dissociative or even somatic kind of expression. So yeah, a lot of times, just the way that people conceptualize the effects of trauma are it's more easily understood or described in like physical terms. Sometimes like even spiritual explanations are more common. And when I went to Rwanda for about a month during my residency with Partners in Health, and a lot of the folks we saw there had spiritual explanations for their psychiatric symptoms, specifically trauma. Rwanda had a horrific genocide, and a lot of the folks we saw were still reeling from that, essentially. But they, instead of seeing their hypervigilance as trauma, they saw it as, oh, my neighbor put a spell on me, or like their version of kind of voodoo type of explanation. So it was really interesting to see that, and I think poses a lot of questions for how you treat that or manage it. So there's quite a bit of research on the neurobiology of PTSD, however, not a lot on complex PTSD, and even less so on ICD-11 defined complex PTSD. A lot of the differences and findings that we do see are located in the limbic system. So just as a kind of quick refresher, here is a picture of the limbic system. It's kind of, again, colloquially thought of as the fight or flight area of the brain, the kind of emotional, primitive, instinctual, emotional center of the brain. And it's comprised mostly of the thalamus, which is here, hypothalamus, the amygdala, which again is responsible for a lot of those kind of fear and anxiety, aggression type emotions, also with kind of decision-making, conditioned fear. And then the hippocampus, which is down here and is more particularly related to memory, specifically like emotional memory, memory consolidation. And these are all kind of interconnected with the singular cortex, specifically the anterior cingulate cortex is most commonly seen associations with, and then also the prefrontal cortex, which is again a higher level kind of cortical area that kind of is involved with dampening down some of these emotional responses from the amygdala. So when looking at complex PTSD specifically, there was another fMRI study. This one was done in Australia, published in 2021. And basically they took folks with complex PTSD, classic PTSD, and trauma exposed controls. So people who still had trauma, but didn't have essentially expression of pathology. And they presented them with threat stimuli in the fMRI. And they found that both PTSD groups showed increased amygdala activation and reduced dorsolateral prefrontal cortex activation versus controls. And furthermore, the complex PTSD folks also showed increased insular and right amygdala activation versus just classic PTSD. So their kind of conclusion from this was that, yeah, folks with PTSD or complex PTSD are having overactivation of that kind of emotional center and reduced ability to kind of dampen that down by the cortical areas. Interestingly, though, some other studies have shown that there was increased activation of those cortical areas, so dorsolateral prefrontal cortex, ventromedial prefrontal cortex, and anterior cingulate cortex, in reaction to negative emotional stimuli in folks with complex PTSD. So the brain was, they postulated, working overtime to try to like tamp down some of that emotional reactivity that was coming up. And they found that that was similar to folks with classic PTSD, but the opposite of borderline personality disorder. So again, a little bit contradictory to some of the other findings. Most of the studies did agree that folks with complex PTSD have a bias towards encoding negative emotional memories versus like positive information, specifically positive emotional memories. And that's kind of mediated by the hippocampus, and also seen similarly in borderline personality disorder too. So how does one make the diagnosis of complex PTSD? Right now, I don't, because we typically use the DSM-5 and it is not included in there again. And right now, we're using mostly ICD-10 codes for billing and things like that, which again, does not have a complex PTSD. So really what I do with a lot of my patients is, give them a diagnosis of traditional PTSD if they meet criteria, and then kind of like talk with them a little bit more about how I see their trauma influencing their other symptoms, discuss a little bit more in the formulation, things like that. There's also a very high comorbidity, unsurprisingly, with things like mood disorders, anxiety disorders, substance use disorders, and even physical health comorbidities too. So that is something that you can, diagnose and treat people for as well. There is a questionnaire out there that can, or screener, I guess you could say, called the International Trauma Questionnaire. That is a validated instrument. It's essentially an 18-question self-report that really can help you differentiate between classic PTSD and complex PTSD. It kind of delineates, it asks patients about all those symptom categories that are listed in a CPTSD diagnosis. However, it cannot discriminate between borderline personality disorder and complex PTSD, so there's that limitation. So we'll talk about treatment too, because I think that's more of a interesting and kind of practical aspect to a lot of this, and something probably we would like to know in terms of how we approach our own patients that we're seeing. But unsurprisingly, psychotherapy is kind of the mainstay treatment for complex PTSD. Although, again, there is not a lot of data out there specifically about the ICD-11 defined version. So instead, what people and what the literature has done is kind of look at evidence-based treatments for PTSD and borderline personality disorder, and then kind of adapt those and test them out in patients who kind of have symptoms of both domains, or like symptoms of complex PTSD. So I just to give people a little bit of a background on the more evidence-supported psychotherapies for PTSD. These are things like prolonged exposure, which is kind of pretty much an exposure-based treatment, which can include both imaginary and in vivo traumatic kind of events. And basically, you kind of work in weekly 90-minute sessions to kind of process these and like learn ways to kind of cope with some of the traumas and that are brought up in the exposures. There's also cognitive processing therapy, or CPT, which is pretty common, and there's quite a bit of literature supporting that. And basically the idea with that is you are trying to challenge some of the dysfunctional cognitions and emotions that are related to trauma so that you can essentially cope with things better. And then EMDR, which is eye movement desensitization and reprocessing, which a lot of us are probably familiar with. But this is also somewhat of an exposure therapy where the patient discusses an exposure or a traumatic memory, and then also simultaneously engages in this kind of bilateral stimulations, whether it's eye movements or tapping. And we don't fully, I think, understand the mechanisms of this, but there is some evidence to show that it can be helpful for reprocessing trauma. There's also other kind of individualized, manualized psychotherapies. I won't go into these, but cognitive therapy, written exposure therapy, which is more of like a narrative form of psychotherapy, present-centered therapy, and then cognitive behavioral therapy as well. And then to give you background on psychotherapy for borderline personality disorder, probably the most common and evidence-supported one is dialectical behavioral therapy, or DBT. And this really came about, and it's considered to be a third wave CBT treatment. And it took a lot of principles, like specifically the behavioral principles of CBT, and incorporated them with Zen Buddhism, which is like things like mindfulness, being in the present moment, and the idea of dialectics. So dialectics, if you're not familiar, is essentially this idea that there are two sides to everything. There's a duality to life. And particularly in DBT, they focus on the dialectical aspect of acceptance versus change. So sometimes, that might seem a little contradictory, like, well, do we need to accept things the way they are, or do we need to change them? And really, dialectics challenges a patient or anyone to kind of consider both sides of that, and where you might be kind of on that balance beam, if you will. So I really like DBT. I've lectured to the residents about it a lot, so you guys probably have heard me talk about it, but it's a really interesting and unique treatment that was developed by Marshall Linehan back in the, I think, late 80s, early 90s. And traditionally, she made it as a 12-month program that was a pretty intensive treatment. So patients would do individual therapy as well as like a skills-based therapy, which is usually done in a group setting. And really, they would target various treatment hierarchies. So you have to first address things like safety issues, so suicidality, self-injurious behavior, and only then can you start talking about like treating emotion dysregulation. And then only after that can you start talking about like other goals that you have in life, like getting a job or going to college or something. So it's very kind of structured in that way. And the skills in DBT focus on kind of four main categories. There's mindfulness, emotion regulation, distress tolerance, and interpersonal effectiveness. So again, these get like right at those core symptoms of borderline personality disorder / CPTSD. There's also a treatment called mentalization-based therapy, or MBT, which is quite evidence-supported for BPD. And then schema-focused therapy and transfer-focused therapy. And these bottom three are kind of more psychodynamically oriented therapies that also include cognitive and skills-based techniques. MBT is more about kind of observing the state of mind and your own cognition, your own thoughts, and then creating alternative perspectives or cognitions that are more adaptive. Schema-focused therapy is more kind of focused on identifying maladaptive patterns or maladaptive ways you might see life, and then also trying to modify that. And transference-focused is really interesting because that really utilizes the relationship between the patient and therapist to kind of bring up maybe some of the interpersonal issues that someone might be having and kind of using and confronting some of those issues in the treatment to help move past it. So with that background, what are some of the, I guess, modified treatments that have been tested out with complex PTSD? So the first is a version of DBT that was specifically formatted for PTSD called DBT for PTSD. And it is a multi-component phase-based program, which essentially builds on a lot of the foundations of DBT and then adds these trauma-focused cognitive behavioral interventions, as well as some techniques from ACT therapy, which is acceptance and commitment therapy, as well as compassion-focused therapy. And so this has been studied, but probably one of the bigger studies that have looked at this was a randomized controlled trial in Germany. And they took patients, I think they were all women, yep, at 3 outpatient clinics. And the patients there had been diagnosed with PTSD related to childhood abuse. And they also met 3 or more criteria for borderline personality disorder. So they were really trying to capture, that group that met criteria for both. And then they split them up, and they essentially gave one group DBT PTSD therapy for about a year. That included like 45 sessions. And then the other half, essentially, they did CPT, which again is one of those evidence-based therapies for classic PTSD. And they found that over the year, both groups did show improvement in their PTSD symptom scales. However, the DBT PTSD group was statistically superior. Patients were less likely to drop out of treatment, which is a huge problem in this patient population. And they also had higher rates of sustained symptomatic remission as well. So this was in support of this DBT for PTSD treatment. There's also another adaptation of DBT, which added prolonged exposure, which is again, another one of those evidence-based treatments for classic PTSD. And here, as you might expect, it's just kind of a combination of doing that exposure work, but also incorporating DBT strategies like the skills, like validation, to kind of target some of those reactivities to or fallout from the exposures. And this was studied in a randomized controlled trial in Seattle. Again, all women in this study. And this was actually done by Marsha Linehan's group. She was the founder of DBT. And so some of her study team kind of headed this RCT. And again, these female patients were selected because they met criteria for both classic PTSD and borderline personality disorder. And then they were given either DBT alone or this DBT plus DBT PE, it's a mouthful, for 1 year of treatment. So essentially with this protocol, they gave the DBT group just a DBT, and then the other group did DBT for several months. And then afterwards, after they had kind of developed coping skills, safety mechanisms, they kind of added this DBT PE protocol, which again is a combination. They found that the DBT plus DBT PE group had about 80% remission of their PTSD symptoms, compared to only 40% in the just classic DBT group. They also had a lower likelihood of self-harm or suicide attempts, and also less dissociation. They did have also improvement in social adjustment and overall functioning. However, it didn't really extend to the interpersonal or quality of life domains. So there's just no real difference there. Interestingly, though, and I think this is a big limitation of the study, there was very high dropout rates. So about half of the 17 people in that DBT plus DBT PE group never actually got to the second part of it. They didn't do the DBT with prolonged exposure. So I think that's kind of limiting in terms of what they could draw from the conclusions. And then the last kind of, formulation of therapy for complex PTSD that has been studied is the STARE treatment, which is skills training in affective and interpersonal regulation. And this is more of an adaptation of kind of a combination of CBT and DBT. It's again a multi-component sequential approach that's usually done over about 10 weeks in weekly sessions. And it focuses a lot on psychoeducation on the impact of trauma, as well as emotion regulation and interpersonal skills. And I won't go into the studies for this one, but essentially when they looked at STARE treatment with the addition of narrative therapy, so again, kind of like more of the descriptive or kind of bigger picture type of therapies, they did find that it was quite effective for people with childhood abuse, interpersonal trauma, in reducing the symptoms compared to just prolonged exposure therapy. Now, pharmacotherapy, I think this is probably interesting for a lot of us to consider. As you probably know, there are no FDA-approved medications for borderline personality disorder or complex PTSD. For classic PTSD, there are only two, which are sertraline and paroxetine, and there's some other off-label medications that are evidence-supported, but not formally approved, and those are fluoxetine, venlafaxine, and prazosin. And this kind of presents a problem because we don't really have medications for these patients. So the way I kind of look at it and approach it is trying to use medications as a tool to manage some of those associated symptoms so that patients can be more regulated and engage in therapy, which again is the mainstay of treatment. And obviously treating comorbidities, that's something we can do. We can diagnose and manage those with medications. That can be very helpful. But really, you're kind of, there's only so much you can do specifically for some of those, particularly like DSO type symptoms. So my kind of approach, and again, this is just my personal, my personal, thoughts. These are kind of the medications I most classically use with my BPD complex PTSD group. And again, I'll mention that these are all off-label. I do use SSRIs I find that escitalopram is actually usually the most well tolerated in this group. Not fully sure why, but in my experience, it tends to be a little less stimulating than something like fluoxetine. Perhaps that's a little bit, it helps ease the transition a little bit. However, sometimes I will still use SNRIs, particularly if someone, is struggling with a lot of the, I guess, kind of fatigue aspects of things, or the kind of numbing aspects of things. Sometimes like having a little bit of that extra norepinephrine stimulation in there can help. I do use lamotrigine quite a bit. That lamotrigine has been studied a lot in borderline personality disorder, and really results have been mixed. But I find that sometimes it really is kind of the most effective medication in terms of helping folks with the emotional reactivity piece and also irritability. Again, there are some downsides to it. You have to start low and titrate up very slowly over the course of weeks to months. But I have a couple, many patients actually who have done quite well on that. I will use prazosin for trauma-related nightmares. And then I actually really like the alpha-2 agonists like clonidine and guanfacine to kind of help, again, tamp down that autonomic reactivity that's oftentimes associated with a lot of the emotional reactivity. You have to be, again, kind of careful with these, and they don't always work, but sometimes it can really help folks just kind of, again, turn off that more amygdala type of sympathetic response and get into more of a executive function, parasympathetic state to kind of help them proceed forward in a mindful manner. Sometimes I'll use atypical antipsychotics, particularly probably most often quetiapine or spironone, sometimes Saffris even, for either the psychotic symptoms or like severe sleep disturbance. And I really do try to avoid benzodiazepines because, there is a higher propensity for substance use disorders in the population. And also there's been some literature that has suggested that benzos actually worsen kind of trauma memory consolidations and are just not helpful. So my approach with medications in this patient population is, again, to start low and go slow. I think a lot of these folks, again, have a propensity to somatic manifestations of things. And so oftentimes they're more sensitive to side effects, or they feel something in their body and kind of freak out about it and stop taking the medication and completely write it off. So I start very low doses, like baby doses, and then kind of just gradually go up. I also really like giving patients choices when it comes to medications. So it's very rare for me to give one recommendation and say this is what we should do, or this is what I recommend for you. With the majority of patients, I will give them usually 2 options, sometimes 3, with the rationale of why I'm choosing that, risk benefit, side effects of both, and then let them choose. And it's interesting, a lot of the time they'll kind of go with the one that my gut was also going with, but a lot of times they'll pick the other one and they'll have good reasons for it. Then you can kind of ask them, well, why did you make that choice? And oftentimes it totally makes sense. So I think that really involves patients in the shared decision-making and helps with buy-in for treatment too. And with medications, I do set pretty clear expectations about, the limitations of medication in this disorder, what they can help with, what they can't. But also trying not to destroy all hope, saying that we'll continue to assess things, we'll have a backup plan, if this doesn't work, call me and we'll switch to the other option, or things like that. And I think that helps people feel supported in that way. And a lot of kind of what I just mentioned is kind of based in trauma-informed care, which is another, I think, helpful and practical way that you can approach the complex PTSD patient population. I won't go too much into this, so we can leave some time for questions and everything like that. But I do think that there's a lot that we can glean as clinicians from trauma-informed care. And it's essentially, for anyone who's not familiar with it, it's a framework, kind of a conceptual framework that really acknowledges the frequency of trauma, acknowledges the impact of trauma on people's lives, and kind of informs how we approach people with that mindset. So again, it's not a therapy itself. It's more of an approach or a strategy. I kind of think of it akin to motivational interviewing, or even, even like serial technique or something. Like, it's not what you're doing, it's how you do it. And you're kind of, again, utilizing the strengths-based perspective that really emphasizes resilience instead of just pathology, just being, sick or just having problems. And you can apply this to, your own personal practice, or ideally systems will do this too, like hospital systems and clinics. So SAMHSA has done a lot of research into trauma-informed care, and they've come up with this kind of schema, the 4 R's, which is realizing the impact of trauma and how common it is, recognizing the signs and symptoms of trauma in individual patients, as well as families, communities, responding by kind of using our knowledge about trauma, about how to approach an individual, and also how to approach bigger kind of systems issues, and then resisting re-traumatization, which essentially is, just trying not to make things worse. And they kind of outline these 6 principles of trauma-informed care. So first off being safety, of course, physical, but also emotional safety. And we'll talk about like kind of practically what this looks like in a second, but obviously you can't be treating someone if they don't feel safe with you. So making sure that they are really feeling secure before you move on with other treatments is important. Trustworthiness and transparency is another big component. Peer and social support, collaboration and mutuality. So this is just kind of, again, getting at patient-centered care. This goes along with the empowerment, voice and choice type of thing, making sure that you're hearing what your patient is saying to you, kind of helping them develop a sense of mastery, sense of agency, sense of self-efficacy, because a lot of times, particularly in patients with, decades of trauma, they really probably don't feel really in charge of their own lives. They probably don't feel like they have any agency in how things turn out, just because of, all the terrible things that happen to them. So really, if you can kind of strengthen their own, agency and self-efficacy and things, that can be extremely therapeutic. And then, of course, having awareness of cultural, historic, gender issues, etc. So practically, what does this look like in the office, for example? With my patients, I spend a lot of time just like building rapport and trust. Sometimes it takes months, sometimes it takes years, but I really do prioritize that, because I think that these types of folks, again, have a high propensity of dropping out of treatment, or running away if they don't feel safe or heard. So as much as you can do to really lay the groundwork for that trust and that relationship will help a lot. I also let patients know what to anticipate as best as I can, and try to give lots of forewarning, like if there's going to be a change or if something's going to happen. Even like going on maternity leave, I try to tell patients really early, and then like remind them each time I see them, just so that they are kind of like preparing for what's going to be happening, and it's not an abandonment at the last minute, like, okay, I know this is going to happen, she's coming back, that kind of thing. There's also ways you can really utilize your words and phrasing that can be helpful. So particularly, again, focusing on more positive aspects, or using non-judgmental language. So like, instead of saying you're late again, if a patient walks into their clinic appointment, 15 minutes late, you could say something like, what happened today? That caused you to come in late. And then it's more, it's taking the focus off of like, it's your fault, you messed up, and kind of diffuses it to what situational things happened to you to kind of contribute. Same thing with medications. Instead of, why are you taking your meds? you could try saying something like, what's getting in the way of you taking your medications every day, or what would help you take it every day as prescribed. And then, again, we're kind of reframing formulations and approaches to include more strengths and more positive factors, not just, the symptoms or the illness. And I think we all, and myself included, tend to fall into that habit a little bit of, the patient comes in, how's your depression? How's your insomnia? How's your anxiety? It's just like, that's part of our assessments and how we have to document things for billing. But if you can kind of change that narrative a little bit more to, what good things happen, or what keeps you going, or, I don't know, what are some of the coping skills you used? It helps people to see their own selves as more strong, I guess. One thing I would also say is be very aware of a possible reluctance of patients to give up trauma. And this can be conscious or unconscious, but essentially, a lot of patients we see with complex trauma, it's very familiar to them. That's how they see themselves. That's how they've lived their lives. It can be not comforting, but it's familiar, I guess. And so if you're trying to change that or help them move on, or stop using some of these maladaptive behavioral patterns, that's probably scary to them too. And that probably feels very unfamiliar and very uncomfortable. And so there might be, again, kind of a subconscious reluctance to make some of those changes. And that actually helps me a lot as a clinician, because I can understand that, like, I get frustrated, yes, when people are doing making the same bad decisions over and over again, or having this, coming in with the exact same personal conflict with their spouse or whatever. But, you can kind of at least understand maybe some of what perpetuates that, and help in different ways. DBT would also encourage you to use a lot of validation when you're approaching these patients. So, validation really is just kind of supporting the patient and their experience of things. So you don't want to validate things that aren't true. So if patient says, like, I'm worthless, I should just kill myself, like, you don't want to like validate that, but you can validate the distress that like they're experiencing with that. Like, I can understand how you might feel hopeless in that situation, and then talk about that. And validation, it's kind of the opposite of like problem solving in a way, which you do use problem solving in DBT also, but it's kind of, if you try to approach something like, oh, well, why don't you do it this way? Or, oh, well, next time, don't worry about it so much. Or like, oh, it's not such a big deal. Like, that's very invalidating. People feel like they're not heard. They feel like, I should just get over it, or something's wrong with me. But if you can really validate like what's at the core of some of those even problematic behaviors, people, I think, can really engage with you better in treatment. There's also, kind of a recommendation to not like let patients completely dive into their traumas. So sometimes when I start asking about particularly complex traumas, people just want to like rehash everything, and they completely open the floodgates and get dysregulated. And that's not helpful for anyone. So I try to kind of limit that, and again, focus on how the trauma may be affecting the person themselves, have more of a narrative approach, and have a kind of more positive reframe. If that does happen, however, and someone is just, getting completely dysregulated in session, I will often use grounding techniques and emotion regulation skills to kind of help them come back to the present moment. And there's a lot of that delineated in DBT, like the workbooks and literature out there. So yeah, definitely something that you can incorporate even into like a 20-minute med management visit if you need to. And then DBT would also kind of encourage you to not treat patients as fragile. I think a lot of times these folks kind of can be scary to treat, especially with ones that have a lot of suicidality or self-harm. But really, if you treat them that way, or don't give them kind of the respect of seeing them as a whole person, it really, I think patients pick up on that, and they don't respond well if you kind of are constantly walking on eggshells around them. So I would empower you in a safe way to kind of, push your patients when they need to. And then, also think about yourself too. Whatever you're treating, if it's classic PTSD, complex PTSD, borderline personality disorder, it's challenging work. It's really hard. There's secondary trauma that we pick up on. There's a lot of countertransference that can come up during the treatment. And one thing I really love from DBT is the idea of the consultation team, which is a bi-weekly meeting of everyone on the treatment team. So therapists, medication managers, nurses, where everyone kind of comes together to essentially support each other and support treatment. They kind of talk about challenging cases, manage your own countertransfers and affects, and kind of help remotivate each other when people are starting to feel burnt out. And there's this, they call it the phenomenological agreement in DBT consultation team, which everyone agrees to practice. And it says that we agree to practice non-judgmental stance and search for empathetic interpretations of the behaviors of our patients, each other, and ourselves. And I think at the end of the day, that's really why I like the idea of complex PTSD so much. It helps, I think, provide a perspective about why patients might be behaving the way they are, or why their symptoms are the way they are. It's not just because they have a personality disorder or they're a bad person or something's wrong with them, but there's someone who's been through a trauma that's so complex, that's so deep, that it's literally changed the way they view the world and themselves. And I think that's a much more compassionate way to kind of look at people with these disorders. And I really do think that, regardless if you think complex PTSD and borderline personality disorder are the same or not, I think it's an opportunity for us to all kind of reconceptualize these symptoms and presentations in a way that's much more destigmatizing and possibly more accurate too. So the last thing I'll just say is kind of directions of the this area, especially diagnostically. Will DSM ever create a separate complex PTSD diagnosis? I don't know. I don't think it's great in its current iteration, because when you just lump kind of the DSO symptoms in with just a standard PTSD diagnosis, I think that makes it less specific, makes it harder to research. It's not as helpful for treatment planning. Even talking with patients about it, it's more murky. So I do think there's some utility to separating them. I don't know if they're ever going to do that, though. I kind of think that they might go more in the direction of a trauma spectrum disorder, where they kind of acknowledge the kind of common background of trauma and the escalating, severity of it. Whereas like PTSD is kind of on the, less severe end, even though it can be pretty severe. And then complex PTSD and then kind of borderline personality disorder might be kind of on the further spectrum. So I don't know, it remains to be seen, but I think it's all very interesting and and just a helpful way to kind of approach patients and also approach kind of the way you think about treatment too. So that's all. Thank you so much for listening to me. And I will, take any questions that anyone has. Yes.
I enjoyed the artwork, number one.
Thank you. I'll tether.
What a wonderful presentation. Thank you. A couple of questions about treatment. In the past, we've had people in our department that were great from components of EMDR, and we've had people that thought that EMDR was nothing but pseudoscience. So your thoughts on the EMDR? Another issue that may not be directed to the complex PTSD that does come up in this category are medicines that are purported to be useful to be given immediately after a traumatic event in order to prevent the consolidation of the emotional aspects of memory. So your thoughts on those two topics?
Yeah, good questions. So just for those of you on Zoom, the questions from Dr. Casey are about EMDR, because there's been a lot of, I guess, debate on how effective it is. And then also medications that can be given like directly after a trauma to prevent consolidation of traumatic memories. So I'll start with EMDR. The literature is mixed. There are a lot of studies out there that really feel that it is quite efficacious, and there's a lot that have really, kind of tried to disprove it. In my experience, clinically with patients, and again, I don't do DMR or EMDR, and I don't, I'm not trained in it or anything, but I have had patients who have responded quite well to it. If they're doing it with a skilled clinician, I think that's kind of an important part of it. There's something about EMDR that my patients tell me they like in terms of the just the physicality of it almost. So whether it's, again, the eye movements or bilateral tapping, there's something that helps them when they're engaging the kind of physical sensory world to kind of stay grounded and then be able to process.
Describe what is not everybody knows.
Yeah, essentially, my kind of basic understanding of it is that, the patient kind of goes through traumatic memories with the therapist while simultaneously kind of doing a sensory activity that involves kind of like both hemispheres of physical and mental states. So whether that's like following like a light with your eyes moving back and forth, or like tapping with like once with each hand. There's, again, we don't exactly know the mechanism of how this works, but there's some idea that helps folks stay grounded while they're kind of reprocessing some of these traumatic memories. And there's a lot of, I think, cognitive restructuring that also happens in EMDR. So you're supposed to think about kind of a negative schema that's associated with the traumatic memory that you're processing, as well as then a positive reframe. And then kind of during this process of exposure and desensitization reprocessing, you kind of gradually bring it back to this positive experience so that by the end of it, you're more able to kind of understand it in a positive framework. So I do feel like I've had a lot of patients who felt that was the only thing that's been helpful for them. It's helped them. It can be very dysregulating, I will say. So that's something you have to watch out for. But there is something about, I think, the physical aspect of the engaging the senses that does help people stay in the moment and tolerate the therapy a little better. And as far as medications given like immediately in the aftermath of traumatic events, this is something I actually want to research more, because I didn't really dive into that for this talk specifically, but it's interesting if there's something that we could give to kind of prevent the more traumatic interpretations of horrible events when they happen. I mean, that would be amazing. But I also don't know if that's something that's really possible. I think a lot of it is a lot of how we process and integrate trauma, I guess depends on your own coping skills, your own view on life, your own connections, what kind of supports you have down the road. So I tend to think that it's probably not going to be that simple, but interesting, very interesting. Other questions? Yes.
I have actually this comment on the recently also saw one of your patients that very actually call it. I saw that you used all of us to magnets. I feel like she definitely made that subtle difference to what it was. It's called some of the things that we've been doing with her, very minimal changes in the basis of the expectation. And business understanding of it's very pointing to the work that you have setting expectations of having for example, you work with therapy and advice education that gave her herself a surgical team and things like that. She felt very happy when she told me Dr. Wood said the same thing. But those patients, I feel like we have to, make that, like, the effort that we put into making the distinction between the two, I think, is working. There's a small local use online that fight about this all the time. From therapy and things like that. Advertising themselves, market themselves on that, not focus on the medicine. But it goes back to that point that you said that there's a lot between the research and psychology. Sometimes it's artificial, still absorb, like, versus clinical. So,
Right.
that's why I think it's a wonderful presentation.
Thank you.
Amazing.
Good. Well, thank you so much for that feedback. And yeah, it's murky, you know, I mean, so it would be great if we had a better way to kind of truly, you know, accurately diagnose these folks and then know exactly how to proceed. But yeah, it gets so complicated. And a lot of times, I mean, sometimes, you know, just as the clinician, I feel a little helpless, you know, I can feel like, what am I doing for this patient? You know, again, you know, can try to help some of those symptoms with like alpha-2 agonists, like you mentioned, but at the end of the day, it's like, am I really doing much? I just feel like I check in with her every 6 weeks, and you know, I'm a living, breathing human being, and then she goes on her way, and I think that there's actually a lot more power in that than we necessarily see sometimes. So just being there with someone, being present with someone in a non-judgmental, trauma-informed way, I think is actually can be quite effective, and we're doing more than we think, I guess, is how I hope to see it. But thank you so much. Any other thoughts, questions? All right, I don't think there's anything on the chat, so we can wrap up, but thank you so much again. I really appreciate all you guys listening.